transition from morning to afternoon. I'm Cynda Rushton. I am co-chair of the Johns Hopkins Ethics Committee and faculty in the Berman Institute. I want to welcome you to Ethics for Lunch. As you know, we need to verify your attendance so that we can keep track of who actually attends Ethics for Lunch. As you know, this is our monthly gathering. We're in a new place, so we're a little being flexible today, trying to get acquainted with our space for today and for the next couple of Ethics for Lunch sessions. So to verify your attendance, we need for you to text to the number here on the screen with the code 16890. And if you could do that, that would be terrific. We have no conflicts of interest from any of our panelists today. And I want to welcome you. We are going to take up the topic today of informed consent when patients change their mind. And before we do that, I want to bring to your attention a very important event that's coming here to our community that we're very excited about. It is going to be on April 12th from 5 to 7 in the evening, a dramatic performance of end of life using the Greek tragedies as a way for us to explore that territory together. So it is necessary for you to sign up. It is a free event, but we need to know that you're coming. So if you could please go ahead and register, that would be really great. Please feel free to share this information with others that you think might find it interesting. And I'm quite sure that it's going to be a very engaging and insightful opportunity for us to come together. So before I begin, I want to introduce our panel. Yassin Moskowitz is a neurologic surgeon, a professor here at Johns Hopkins University in the Department of Neurology. Carol Symes, who is a long-standing member of our Johns Hopkins Ethics Committee as a community and family member, and Carol has a lot of experience here in terms of being the family member of relatives, including her daughter, in our own institution, so her insights are always really important. Jackie Bradstock is a registered nurse and is someone who has the opportunity to deal a lot with patients who are undergoing surgical procedures. Jeff Netterman, we are expecting momentarily, and he is one of our risk managers here in Johns Hopkins Hospital. So, get us started with a little bit of background about informed consent. And so when we think about healthcare decision making, we know that about 8 out of 10 adults over the age of 40 are regularly making decisions about their health and health care. And in the survey that was done in 2010, 2.6 million citizens, participants, discussed surgery with the healthcare profession, 97 million discussed a screening test, and 75 million have made a decision about a medication. So there are lots of decisions that are being made in the context of healthcare every day here in our own institution and across the country. We wanted to take up this issue of informed consent today, thinking about it from the point of view of what is the ethical basis for informed consent. Obviously, it is both a legal and an ethical framework that we use very regularly in our healthcare experience. And when you think about it, the ethical basis is largely centered around the respect for an individual's autonomy. And the presumption is that a competent person, a person with decision-making capacity, has the right to accept or reject any medical therapy at any time. And in order to be able to choose, a person needs to have the ability to understand, to have an understanding of the options that are available to them, to understand them, and to choose them freely. We're going to come back to that in just a second. Informed consent also often involves balancing benefits and burdens. And as we know so very well here, there's rarely anything that we do that doesn't have both benefits and often some consequences that may not be as beneficial as we'd like them to be. So we're constantly trying to help people to weigh those options, the benefits and burdens. And in order to do that, they have to have the information that is relevant to them to make those sorts of distinctions and determinations. So I want to just highlight before we get started here what the elements of informed consent are. And there's really three buckets that these elements fall into. Sort of the preconditions, which are the capacity to understand the information and to decide what a person would choose in the situation. And the second one is voluntariness, the ability to make choices in a way that is not constrained by either coercion or manipulation or other external factors. The second is information elements, and that includes disclosure. This is where we need to provide for patients who are making choices the medical information, the facts, the situation. And embedded in that is often an understanding of what the alternatives might be, what information is necessary for that person to have a full understanding of what they are actually choosing. It also includes making a recommendation and being able to use our clinical expertise to make a recommendation about, given all that we know, what we think would serve the patient's goals and best interests. And then the third is understanding, and that is really focused on the patient. Do they actually understand the information that was disclosed to them, and are they able to weigh and deliberate about what choice they would like to choose? The final one is actually the consent elements, which is the person making the decision and their written authorization of us to be able to provide whatever surgical procedure or treatment that we have recommended to them. What's interesting is that a lot of times what we focus in on is the authorization of the form. And so what we'd like to do today is to see if we can think about a perhaps more robust way of thinking about consent, not as just the signature on the form, but what is this process? And how do we respond when people actually change their mind about what they think might serve them best? So in order to do that, we're going to focus today on a composite case that we've developed from our experience. And you all have in front of you, it's a case involving Octavia Mendez, a 72-year-old woman. She was admitted to the hospital with shortness of breath and new onset atrial fibrillation with a rapid ventricular response. She states she's had shortness of breath with usual activities, but when she is able to rest, those symptoms go away. She's had some lower extremity swelling, but it improves when she is lying down. Ms. Mendez is widowed with a 46-year-old daughter who lives nearby with 2 grandchildren. She's active in her church, she loves gardening, she enjoys walking her golden retriever. She has decision-making capacity, and her daughter has been designated as her healthcare agent. She's now in the hospital, and her atrial fibrillation has been brought under control. Her echocardiogram shows severe mitral valve insufficiency and a dilated left atrium. Following the cardiac workup, the surgical team meets with the patient and her daughter to discuss options and to recommend surgery. Mitral valve or repair or replacement is recommended. The risks and benefits of surgery are discussed, as are the risk of the natural history of her mitral valve disease. Throughout the discussion, the patient expresses hesitation about having the procedure. Each time her daughter takes over the conversation saying, "Of course, Mom, we'll have the surgery." Eventually, the patient signs the consent form and is scheduled for surgery the following day. That evening, the nurse who is caring for her over the last few days reviews the patient's preoperative orders and asks Mrs. Mendez how she's feeling about surgery the next day. With her daughter at home, Mrs. Mendez shares that she does not want to have the surgery, and she is afraid that the outcome might be bad. All she wants to do is to go home, spend time with her grandchildren and her dog, and to live her life as long as she can. She shares that with her daughter, who's very concerned about her and is insisting that she have the procedure. The OR schedule is very full, and the likelihood of rescheduling the procedure in the near future is limited. Sounds like a scenario that could be present in our own institution. So what we're going to do is we're going to hear from each of our panelists to get their first perspectives on this case, and then we'd like to open it up to you to have a dialogue with you about the issues that this case raises for you and some ways that we can think together about responding to it. So I'm actually going to start with Jackie as the nurse, and to get your perspective on what it's like to be in that position and what the ethical issues are that kind of come up for you. So, Jack?
Thank you. I think being that bedside nurse, especially the night before sending a patient to the operating room, is an opportune time to have a conversation with these patients. It really opens the opportunity to just see how they're feeling, try to calm their nerves. It's natural to be nervous about a big procedure. I work in cardiac surgery, so this is real life for me. And I think that when she expresses concern, I know that ethically anyone can retract their consent at any time. As the night shift nurse, she probably wasn't there when the daughter was over speaking for her, so you can't speak to that. But you know, it makes you question, was the consent ever valid in the first place? Because was there coercion with the daughter? And I really think that it gives the opportunity for the nurse to then contact our providers and say, we need to have another conversation. The conversation that was held earlier is no longer applicable. The consent is not valid if the patient doesn't want to have the surgery. And I think this happens, and realistically we have another conversation. I'm happy to provide education about nursing care within my scope of practice, and I can talk to them about the chest tubes that they'll have and the pain and how we treat it, and you know, the care that I would provide postoperatively. But I think also including the providers. So on the CVPCU we have a team of nurse practitioners and PAs, and that would be my first line of communication, going to them saying we need more education. And then from there, it's the cardiac surgeon. The fellow is usually the one who gets consent, so including them, bringing them back into the loop, and then obviously including the surgeon and updating them as things need to redress it.
Great. Yasik, would you like to speak as a surgeon?
This is working. So I think everyone in the room is going to be familiar with the kind of normative principles that we frequently talk about and teach in medical ethics, the principles of respect for individuals or autonomy, of beneficence or doing good for people and not harming them, whichever translates as protection, and then justice or fairness. As you know, they come out of the Belmont report, which I think was, correct me if I'm wrong, Mark, was it 1976 or 79, is that what the report was? Which was in part authored by people from this institution. Tom Beecham had an important role in that. And all those principles are outlined there, and I mention it because the entire Belmont report is available online. And if you look in particular at the section on informed consent, there's a nice 3-4 paragraph summary that will just give you all the necessary information that you need to have at your fingertips. It's kind of like reviewing your physiology before you go see a patient. That's about, it's both helpful and limited in the help that it provides. As most of you who are here are based in the hospital and you're both interested and aware of what the difference is when you actually sit face to face with the person. So I'm going to give you my disclosure, which does not appear on my disclosure sheet if I can get it correctly here. And as soon as Cynda mentioned this case and I read it, it reminded me of an experience I had when I was a very young surgeon starting out, trying to do the right thing, being busy and doing operations, with a lot of senior, more experienced faculty over my head to, I think the term is advise me. So I came upon this citation in Henry Marsh's book, Do No Harm, the stories of life, death, and brain surgery. And here he's quoting René Lariche, who was a very distinguished vascular surgeon in Lyon, in France, in his book, The Philosophy of Surgery, a title that is unimaginable today, but The Philosophy of Surgery. Can you imagine this? You know, I like this very much, but you're not going to find it. Anyway, the quotation is, every surgeon carries within himself a small cemetery where from time to time he goes to pray. A place of bitterness and regret where he must look for an explanation for his failures. So thank you, René Lariche. It's nice to see such disclosures, and it reminded me of my own experience. I was just a few years on the faculty, and I was asked by one of the consultant senior cardiologists to see one of his patients who was recovering from some minor heart ailment but had advanced ischemic heart disease. And it was in urinary retention with a gigantic prostate, the sort that cannot be taken care of by medications or by a simple operation. He was living with a catheter. The patient was in his early 70s and did not look bad when you saw him in bed. Most patients don't unless they're very sick. And I was asked, would I perform an operation to remove this and restore his voiding? And I said, well, of course, I went to see the patient, and I talked with him. And, I said, I'll be back the night before surgery, and got everything set up for him. So I went to see him on the night before surgery to sign consent with all the usual stuff, just the two of us sitting there at the bedside. And after signing the consent, he said to me, he says, I'm not sure I really want to have this done. And at that point, you can take one of two roles. You can be paternalistic and be the good parent, or you can be paternalistic and be the scolding parent. So the good parent would say, don't worry, everything's going to be fine, it's not a difficult operation, we'll get through it okay, we checked everything out. That's the good parent. The bad parent, or the scolding parent would say, we've gone to all this trouble to set this operation for you, and now you're going to turn away from us? Do you realize how much trouble you're causing? So I'm not saying that anyone here would ever dare say such a thing to a patient, but these things are not beyond the realm of possibility. So I was kind of the good paternalistic parent, said, don't worry, everything's going to be all right, etc. And indeed it was. The operation took place the next morning. It went great. We didn't lose any blood, which is unusual for a large prostatectomy. He did fine. I came to see him the night after surgery, he was fine. I came to see him the next day after surgery, he was fine. But then, about 36 hours after surgery, I received the information that he suddenly sat up in bed, had a massive MI, and was now dead. So with that in mind, I read Renee LaRiche's comments with a lot of interest. So now I find that I listen to people, and you have to listen kind of with the third ear. What Theodore Wright, a famous Freudian psychoanalyst, called listening with the third ear. There's an intuitive sense about a person, and plus there's all the extremely valuable legal information and normative information that Cynda has presented at the beginning of the preparation. You have to listen and sort of and feel it out. And there are times when the institution will have to take a hit, and that becomes a problem, as I'm sure all of you know. When you come up with a decision that goes counter to the smooth operation of the institution, that is a problem. But in the end, what's really at stake? So I know how I would have faced that situation that I had to face 30 years ago differently now, but that was 30 years ago. It takes a long time to get that kind of experience. So I'll stop there.
Is it on? Oh, it is. Okay. So this case was sort of near and dear to my heart because my father was just underwent cardiac surgery here at Hopkins for an aneurysm, an aortic aneurysm. He's 86, and going in, he had said, well, he had had an ED visit, and it was recommended that he follow up. And he was resisting the follow-up. I said, why? He goes, well, if they're going to tell me something bad, I'm 86 years old and I'm not undergoing any more major surgeries, and that's that. Well, he went to see the doctor, and the doctor said, you know, you have this aortic aneurysm. And he said, you're 86 years old, but you are on one medication, you're otherwise healthy. I would recommend doing it because of X, Y, Z. And if you do this surgery, I think it has a good chance of being successful. If you don't do it, you won't see 90. Well, put that way, he said, yeah, I think I'll do it. Now, fortunately for him, and unlike this case, and I think one of the problems in this case is that the extremely short time between which he was delivered all this information and asked to make a decision, and then to go through all those questions of, well, is it really going to work? You know, what's going to happen? No one really knows. Am I going to make it off the table? So it seems to me that in this case that was very compacted. And I think that really sort of gives you a sense that you've got to be extra careful with this patient and you've got to listen. As a daughter, you know, certainly I'm siding with the daughter. Yeah, Mom, get in there and do it, right? Why wouldn't you? And I think that many times this fear, you know, you have to take the time to tease out the fear from the goal. So it sounds like she's afraid, but her goal is to be with her dog, be with her grandkids, and live out her life. Well, you know, maybe it's the surgery that really, truly allows her to do this because it sounds like she's going to lie down every time she starts to feel poorly, and that's going to limit the amount of time she can do what she wants to do. But I feel like she hasn't been given the time to think through this. So if the surgery wasn't truly an emergency, then to me, the thing to do, being, you know, looking at this from both perspectives, the thing to do would be to take a breath and have a conversation and tease out the sort of normal fear of surgery from the actual decision of I don't want the surgery, because I think those are two different things. And so, you know, OR scheduling be damned, if there was no reason, like, you know, she wasn't going to die tomorrow if she didn't have the surgery, then I think giving time and giving validity and voice to her concerns is really important. In my case, fortunately, my dad had about 3 weeks in between, and so he had a meltdown, and then he came back from it, and he was fine by the time he went into surgery, and everything was great because of great care he got here. And so I can see both sides, but in my reaction reading this is that this woman needs a little more time to think on her own and ask questions, and to me it would be a rescheduling kind of thing.
So thank you. I'm wondering, one of the themes that you've sort of highlighted is this, how do we distinguish between ambivalence and sort of normal preoperative jitters from refusal? So what are your thoughts on that?
Well, the more people you help go through surgery, the more you get a sense of what the difference is. So I think it's natural to have worry and anxiety about an operation. But I think this matter of a serious hesitation is something else. And it's hard to say what it is in this particular case. I think Carol's point's very well made. It's a complex operation. Language may be an issue. Time may be needed. And time has become an increasingly rare and precious commodity, especially in a busy system. So a patient comes in, decisions are quickly made, recommendations are made, sign here, etc. And it's not like perhaps it was at one time when we had fewer operations to offer people, but perhaps more time to offer them. So I think, again, this is a matter of knowing the patient, and if you're not sure, is it really wise to go ahead? I'm reminded while Carol was speaking about this, there's a famous Harvard Business School case which deals with an adventure crew that would take people on climbs of Everest. And it's meant to illustrate what's called investor syndrome. These were high-ranking CEOs, people who had great ambition and wanted to get to the summit of Everest, but they ran into trouble with weather, etc. And there was uncertainty about whether they should go ahead or go back. The decision was, because so much had been invested into it, they would go ahead, and a number of people died as a result of that. So it's a famous case based on knowing when to fold your cards. And I think that's part of the issue here, knowing when to fold your cards. And I think it does have to be on a case-by-case basis, and that's why it's appropriate that this is within the context of today's discussion. So that's my sense. You just got
I mean, I think we're all familiar with the phrase that nurses are the last line of defense. So I really feel true to my heart when I say, when you have that conversation with a patient, you take it seriously. You know, the operating schedule is packed, but it's a patient's future, it's their life, it's their quality of life, it's how they want to live. And so it means likely canceling the procedure the next day to give time to educate, to have the patient absorb the information, process, have another conversation with her family. And I think that's the most important part. And I know sometimes we get a little pushback from the business side of how a hospital runs, and we want to keep things on schedule and on track. And there may be push that she is severely ill, and maybe we wouldn't discharge her, but she wouldn't be the first patient that sat in a bed pre-op for 2 or 3 days to process the information.
Carol, you have anything else to add?
No, I mean, I think I said, I think that taking a breath and listening, obviously, that's the thing, and that discernment piece. And I would say as sort of a practical process thing, though, the one thing that I see is often a problem for the patient and for the clinical staff that may be on them is how quickly are you able to have that discussion with the surgeon, with the attending? How meaningful does that, discussion become sort of up or downstream? And getting that sort of buy-in that this is worth taking the time for. And I think sometimes you do get pushback, and people are busy and they have the schedule and they want to stick to their schedule. I also think in this case, that conversation needs to be had. She doesn't live in a vacuum, right? So she's the most important person in this scenario, but there are other people, and the daughter has been involved in the conversation too. So, requesting from her, who else do you want to have involved in this conversation, and how do you want that to look? Do you want to make this decision on your own or with other family members? So I think getting down to what the patient wants and who she wants involved in that decision is important.
It's a really good point. So I want to open it up to you. What sorts of questions do you have, or those of you who have had experience working with people who may be ambivalent or may actually change their mind? What have you found to work in those circumstances?
So I've always kind of wondered,
I don't think it's turned
Push the
on.
little button for 2 seconds.
so I've always kind of wondered why the hospital doesn't have the adult equivalent of child life specialists. Because when I used to be in the pre-op area and the child life specialist came in, she would always say the greatest fears of the unknown. And she would talk about what they're going to do once they're in there. She would explain to the child exactly what it's going to look like. This is the mask they're going to put on. This is, you're going to go back, you're going to take 2 breaths, like the basic steps. And not only would the child suddenly become more relaxed, I'd look over the parents and they would be totally relaxed at that point, knowing just what the simple day-to-day, what that would look like, the whole picture. So I've always wondered why that isn't just extended over to adults.
I wish I had the answer to that. But I don't know, it sounds like it might be an interesting suggestion. Allison?
So I want to bring up 2 things. The first is I want to talk about the importance of age and gender and race here, because my concern is that if this was a 46-year-old man having an operation and his 70-something-year-old mother kept saying, oh, he'll have it, we would shoo her out of the room. She would not be given much credence. And so I worry that our patients actually don't all have autonomy over their bodies, or the autonomy they have over their bodies is being determined in part by their demographics, which I find concerning. The second thing I want to bring up is that we've talked a lot about jitters and uncertainty, and that is what happens in 90% of the cases. But this is a patient who has said point blank she does not want to have the surgery. And we're having a larger conversation right now in this country about consent and what people can do to your body. And this is someone who has said no, and no has to mean no. So I worry that we're taking no and turning it into she's not sure.
Okay, first of all, to your point, yes, I agree wholeheartedly. And I find that when things are done in that manner, so in my father's experience, it was very much like that. The docs and the fellows very much approached him in a very stepwise sort of, like, this is what's going to happen next, this is what we're going to be doing, this is what, I mean, it was very succinct and very detailed, and it did give him comfort, it gave us comfort as well. So I think that it sometimes does happen that way. I don't know that that's the norm, but in his case, it was, and it is very comforting. And having gone through the peds, my daughter has CF, so she's been in the CF clinic here for years, and having gone through that peds, child life piece, that really does make a huge difference. And then, so to Allison's point about no means no, I agree that no means no, except that I do think that fear can play a part. I don't think that we could discount ambivalence, and I think that is no means put the brakes on, but it doesn't mean walk away. So in any relationship, you know, if somebody, say, is proffering sex to somebody and they say no, that means no, right? But it doesn't mean it's always going to be no as the relationship continues and understanding develops and all that thing. So I do feel as though, yes, it is incredibly important. And I do think that, yes, we should consider relationships, and that's why I think that deep dive with the conversation after she said no, and you go back to her, the deep dive, and who's the one involved in this decision-making, and who has a stake in this, and to where does the patient herself or himself draw that boundary, right? So I think that's all about conversation, and that's all about truly consenting and truly being informed and truly listening to that. So.
I mean, I can just add to your point that we do have some cardiac surgeons that are almost artists. They attempt to do their best in drawing pictures to explain the surgery to their patients, and we even have heart pillows with the anatomy of a heart, so when they get a bypass surgery, they can see exactly where things are. So there are attempts made to break it down to a more simplistic, artsy language that kind of helps people feel at ease. You know, we don't show them a chest tube that's going to be hanging out of their chest, but I don't think that's calming any nerves, per se, either. And then, you know, to Allison's point, I mean, I agree that no means no, and we should stand for that, but I also can see how no means no right now, and then it just requires more inquiry and asking questions and just figuring out if that means no forever or if it just means not today.
I think one of the important points here is how we can distinguish between, you know, a temporary no and how we respond to that. Because as you pointed out, Yatsika, about being the paternalistic or provider of trying to convince the person that this is the way that they ought to proceed, versus really taking seriously their refusal and trying to understand what the basis of it is. How that unfolds is also important, because I think sometimes our patients feel somewhat badgered that there is a particular recommendation that's been made, and that when there's a refusal of it, there may be numerous attempts to try to convince the person to go forward.
Perhaps it was your comment about bringing child life in, which is a wonderful suggestion, wonderful suggestion. But I couldn't help thinking the other day when my little daughter sort of dropped something on her toe and scraped the skin off. And it was my role to put the Band-Aid on. So Allison, a little bit to your point, said, don't touch it, don't touch it, don't touch it. And it took a while to get to the point where we could just get the Band-Aid on. She kind of wanted it, but she didn't. And yet there's the very realistic thing that you address, which is the issue of no means no. There's no question about that. But it's part of it is the art of trying to figure out where you are in all of this and the complexity of the context. That's all I have.
The complexity of the context includes ambivalence not just about the surgery as such, but ambivalence about the relationship with the daughter, which is to say, it's perfectly, one can autonomously give away one's authority to decide. If I say, I don't want the surgery, but on the other hand, I want to do whatever my daughter says, I think that is, at least if it's explored properly, an exercise of my autonomy. Just like I, with full capacity, can say, I want my healthcare agent to decide things. Don't bother me, doctors, talk to her. So there is this interesting additional ambivalence and dynamic as between the two individuals, as well as the surgical procedure.
If I could just add to that, Jack, this is a very important point. It's the issue of substituted judgment, which underlies the entire case. In issues of substituted judgment, the one other thing that is very important to keep in mind is that it's not absolute. It's subject to sort of a consensus about, you know, this term, the best interest of the patient, which is a loose term at best, but does introduce the possibility that multiple people can have an opinion about whether the substituted judgment is really for the benefit of the good of the patient.
I can talk pretty loud, so I don't know that I really need this. I'm Susan Longley. I'm one of the senior counsel for the health system, and I'm sorry Jeff didn't make it. I'm sure it was something very significant.
So you could take his place.
So I can, yeah, so I can try that. So, I agree completely that informed consent is a conversation, it's a process. But ultimately, when the signature is on the piece of paper, it becomes a contract between the healthcare team, the provider, and the patient. And so, when I hear this, I think people make decisions for lots of reasons. I think coercion, the concern with coercion is really more if the provider was saying, if you're not going to follow my recommendations, then there really is no need for us to continue this relationship. I'm not going to see you any longer, right? That's real coercion. So, the fact that she might be considering and doing something because her family wants her to do it, if she has capacity, as Jack said, I totally agree. She's got a right to make that decision. But when you hear that now that it's quiet in the night before, and she's saying, I really don't want this, I think you have to hit the pause button, and you have to revisit whether or not you truly do have consent at this point. And it should be done at a point in time where she doesn't feel pressure from her family, so it's an interesting scenario, but certainly there's a pause. If you may have, I think perhaps you probably do have informed consent, but when she said no, you absolutely, from my perspective, have an obligation to explore, do we still have informed consent?
So that's a really important point, I think, the pause. That even though it's inconvenient and it disrupts everybody's plans, it is significant enough that we need to go back and re-verify if in fact the signature we have on the paper is still valid. And that is something that I think we need to, it needs to be an expectation that when a nurse detects that our system is going to respond in a way that acknowledges the importance of this process, even if it is inconvenient. Yeah. Yes.
I'm going to somewhat dovetail off of that, and the childlike comment as well. Giving pause to the patient being concerned or expressing any type of anxiety. Absolutely, and I am taking this in the most literal area, reading this, and where the surgical team, sounds like they spend a quality time with the patient and with the daughter, explaining risks and benefits, other treatment options, and ultimately, while this was all being done, throughout the discussion, the patient expresses hesitation about having the procedure. So I'm reading this throughout the discussion, so it's more than once. So the pause really should have taken place then, especially knowing the team going in there, and I'm just thinking it's all providers, that there's not a social worker. Having spent 17 years in our adult trauma and critical care ER here, anytime information is given like this, the doctor and the social worker meets with the patient and the family. And a large part of our role, too, is to make sure we're advocating for the patient and for the family that if there's something that they're not understanding, we're pretty good about picking up body language, to say, Doc, can we just backtrack a little bit to that? And then look into the family, and they're saying, yeah, I don't know what that means. I don't know what DNR means, but she had full capacity and she could participate. And so I really think the night before surgery totally could have been avoided by addressing each time her reluctance. And that was, that just wasn't done. And then the last point is about her daughter's her healthcare agent. What does that mean? Is that she makes all the decisions for her, even when she is competent and conscious? Or is she the healthcare decision maker when the patient is not conscious and able to express what she would want?
So maybe just, we could probably clarify that point. Healthcare agent only applies when the patient loses capacity. And so I think this is one of the points that sometimes when we have very outspoken family members, we can get distracted from the patient making their own decisions to really being sort of focused more on what the family member is saying. And I think, as Jack said, it could be that she's willing to transfer her authority to someone else, but the mere presence of a healthcare agent designation does not imply that.
So throughout the course of this discussion and this presentation, I've been thinking about something that perhaps has just been sort of glossed over because of the scope and the limitations of meeting for an hour. But I'm struck with the fact that the patient is asked not only to consent to the procedure, but also implicitly then to consent to whatever recovery and perhaps new normal post-operatively. And I would just encourage us all to think about that perhaps her hesitation or her ambivalence may be more rooted not so much in what we as medical professionals have do, but also what her new life would be like, and just encourage us to consider that.
So really
And
great.
I almost was going to bring that up as too, because a lot of times it's what does it look like afterwards? What does my rehab look like? How much pain am I going to have? Who's going to take care of me? All those concerns can certainly contribute to this feeling of I don't want to have this. Am I going to be a burden? Especially when you're dealing with people who are older, they're alone, and their family is, her daughter has young children, this sort of thing. How is that all going to be managed? And, so I think that naming her daughter as her healthcare agent gives her, you have sort of this intent that the daughter knows what she wants, right? You kind of think that way. But it's that aftercare that's as much a part of that process, and I think that was a good point. Yeah.
Can I just add on to that real quick? I think we've got great resources here at Hopkins, and I feel comfortable tying in our social worker at any time to address those concerns. And I mean, typically, I've been here for 8 years, and I can kind of have a feeling when a patient might need rehab after surgery, and I just kind of plant that seed early on where, inpatient rehab might be an option. It could be short-term, it could be longer-term. We, have social work here to talk with you and your family about placement after, or a few other social concerns. So I do think we try to include that in our conversation. Not that it happens 100% of the time, but it is definitely on our radar.
Do you want to make a comment?
Yeah, absolutely. So I just kind of wanted to address the topic of implicit bias. Lisa Cooper over at the School of Public Health has done extensive work on implicit bias with dealing with race and religion, but I'm also curious about the implicit bias that perhaps the provider would be providing to a patient in this circumstance, because a lot of times in our world of relative value units and compensation for different procedures, as well as keeping the OR lights on, these all things that cost money. And I'm curious, how can a provider properly remove themselves from the biases that they may have for moving forward with a procedure? Of course, every provider, when prompted, would undoubtedly say they want what is best for the patient, but the reality and actuality of the situation is that we have these complex motivating factors. And is it our obligation to perhaps bring in third parties or do certain thought experiments to kind of bring this so that we are doing what is best for the patient all the time, rather than what is rather than letting our own motivations cloud our judgment?
Well, I think your point's well made, and you could make an argument that anyone getting consent for a procedure that he or she is doing or stands to benefit from in some way, there's a conflict of interest. And that would include people who are recruiting patients for oncology trials, chemotherapy, et cetera. I think this was one of the issues that came out of Tuskegee and found its way into Belmont in terms of protection, respect for persons. But also with regard to the first point you mentioned, it deals with the notion of the vulnerable populations. And immediately raised the question, who is vulnerable? And how do we decide that? On the one hand, if you want to be really radical about it, and I think you can be, which is to say that we have a very limited understanding of what another person is like. Very limited. We think we know them, but how well do we really know them? I mean, there's been some very good philosophical and ethical work done on this, specifically by Emmanuel Levinas, who writes about the other as someone who you can never totally know, someone who ultimately remains inscrutable, and we have to approach that person from the point of view of that inscrutability. That's a high theoretical kind of concept to carry around with you when you're dealing on a day-to-day basis with informed consent problems. But it is something that belongs in the back of our mind. I mean, if there's any doubt, there's a reason for that doubt. If there's uncertainty about what the patient really wants or thinks, there's probably a reason for that. So that's a subtle thing, because that's only gradually creeping into general social awareness. I don't think that was something that people widely talked about, maybe not even thought about, say, 40, 50 years ago.
So I just on your point, I think the bias shows up in so many different ways, and when we think about the fast-paced environment that we work in and the throughput and production pressures that everyone is experiencing, those factors have an impact on how we respond to these kinds of situations, and how we can become aware of how they're affecting our commitment to really try to understand people and their perspectives, and to see them as, whole beings. Sometimes gets distracted by other things. So I think your point is a really good one. How do we make it possible that when we notice something like that, it's okay to pause and take a look at it?
Yeah. So this might be a little bit outside of the scope of what we're talking about today, because it doesn't necessarily deal with this case study, but what I noticed in this case study is that we have a patient who originally signed the informed consent and then comes back and says no, she doesn't want it. And I'm wondering what kind of ethical issues might look the same or different if the situation was reversed. So for example, if you had someone who originally denied care, or perhaps even signed a DNR or something, and then given the same constraints of scheduling and everything, calls back the next day saying that they want care now. How do we handle this situation? What types of ethical issues might be different than the case we're looking at right now?
It's a great question, and could be a great topic for another. Really, because it brings up lots of very important issues, and some that we've been considering recently in our own consultation process. So I'm not sure if anybody wants to say anything about it now, but it's a great topic for a whole other conversation. Yeah.
I mean, I'll just touch on real quick. I think that most of our providers would do a little bit of investigating what made you change your mind, and have a conversation like that. But I also think most of them would go on to look at the schedule, and maybe that patient would then come into clinic and meet with them, and they would do all their pre-op education. This scenario is where the patient's admitted to the hospital. This is the night before. This is a last-minute decision. But a lot of our patients are elective procedures, and they do have appointments in the clinic, and they're educated preoperatively weeks before surgery. So, I mean, I would say a lot of surgeons would probably accept, the patient and then go on and continue
of surgery.
So just by way of quick background, I've had the opportunity in the past to observe the consent process in research settings. And one of the things that I've taken away from that is that many people have varying degrees of skills at doing that in such a way that there's solid communication on one end of it, where it's high quality, the other side being where here's a form, sign it. So in extending this into the healthcare scenario, I'm curious because each of you have given examples with the heart model, taking the stepwise approach to explaining things and having maybe some background. What are your opinions about having some kind of formal training? I don't know if it would need to be in medical school, if it would need to be a part of a residency, or where that would land, where individuals who are actually in the process of obtaining informed consent for a procedure are able to deal with these kinds of things and be able to do, to the extent that they can leverage their own skills and abilities. Some people are people, others aren't. And to the extent that they're able to really convey the information and to open up that process so that it's truly the case where the patient, in terms of his or her consent, is in the driver's seat. So would you recommend that there would be some kind of training? If so, what would that look like?
Okay, amen. Yes. And so I also think that patients need training and education, and we don't have that. So here's my pitch that all people be educated in this institution and in our institutions in general, because not only are the varying skills on the deliverer of the informed consent, but there are various skills and understandings on the recipient and the person that's being asked to make the decision. So to the extent that we can, discussion earlier rather than later is, I think, for the patient always important. And I do think, I don't know how it would look, but I think I would bow down to the program that offered, kind of an education on how to deliver informed consent.
Agree 100%. And I think two places you could do this where you can kind of at least have a start. One would be to introduce with clinical skills for first and second year medical students. And then for new appointees to the house staff, have at least a training video, which you can watch and show people that there are good and bad ways to do this in small bites. And the problem as soon as you make it a requirement, it's something on a checklist. But the spirit of it, I think you're absolutely right.
Might be interesting to see if simulation might also be an avenue. Yes. Could we, Michelle?
I just have a comment. I think it's just fascinating. A woman who was thought to be alert-oriented and capable and, being loved on and going to surgery, everything was wonderful. And the moment she changed her mind, I don't know it, but I don't feel the love. And to say that the physician or whoever may have not said it verbally, that he was whatever, but body language is important. I just wonder, we spend a lot of time with a person who said no. No is no, unless something else is going on in medicine. I mean, why is it that it appears that she's done something wrong? Everybody don't want to be fixed. I'm sorry if I decided I didn't want to be fixed at the 9th hour. What do? See me to the curb? Shall I never come back? Shall I never get any follow-up? Do I not have a right as a human being to make a bad decision? I mean, what? It just sounds like, what is going on? I mean, I don't want to be her. I mean, her daughter was a part of it, but she wasn't the main person. Now all of a sudden her daughter's front and center. She wants her mom to have the surgery. What is going on for a capable adult? I mean, all different kinds of ways we're trying to usurp her authority. Do this, do that, do that. I said, I don't want it. I appreciate your investment, and I've thought about it, but I don't want it. When is that honored? When is that honored with dignity? With, okay, we don't agree, but we part ways in a good way. Instead of feeling like this kind of hostile environment has been created because I may be afraid, but I may have decided in a debilitated state, in a state where I can't do everything I want. I want to live that way however long I have. What's wrong with that?
Thank you for really, I think, illuminating some of the contours of this particular case, and some of our norms and the ways that we relate to people not accepting our recommendations. That's another part of our bias that we have to also be aware of, and how we can respond to that in the same spirit of respect as we do for the person who says yes. So I think that's actually a really important point for us to sort of end on in a way, to really ask ourselves, you know, are we, when we offer options, are we equally committed to both answers?
I know we want to end there,
But you want to say something.
I
Go
do.
right ahead.
Because I hear you loud and clear, and I don't have any objection to having somebody make a poor decision, and what other people might think of as a poor decision. Like you say, I just want to live this way, and that's fine with me, and I have the right to make a quote-unquote bad decision. So but it does happen, and I've seen it happen in a good way. So a friend whose mother had cancer, of course, all the recommendation was you do the surgery, you do the chemo. She said, forget it. I'm not doing any of that. And of course, everybody was taken aback at first. But she chose not to do it, and everybody respected it. And it didn't mean that they walked away. There was an abandonment. There was care, and there was love, and there was hospice at the end. And she did get good care. So I don't want to think that it's impossible for us to deliver health care or receive health care in that way. Because I've seen it work, and I've seen it work well, when somebody said no, when everybody else thought yes was the answer. And yet, she chose and she lived her life out the way she wanted to do it without being abandoned and with being supported and loved. So I don't want us to think it's not possible.
We don't really know what the denominator is with a case like this, so I suspect if you were to survey the institution and people in practices, you'd find a lot of people who were followed based on their preferences as opposed to being either removed from that practice or somehow pushed into having treatments that they don't want. I mean, I remember when I was a mid-level resident, there was a man who had had a prostatectomy 20 years earlier and was incontinent afterwards. And his management, his way of treating was to take a Campbell soup can with a string and tie it around his waist. He would come in every 6 months, we would check his can, and he would come back every 6 months. I'd mentioned to him about an outbreak, he says, oh, I don't think I want that doctor. I said, fine, see you in 6 months. And then there are patients that we follow that have fatal, terminal diseases that don't want further treatment. We don't necessarily let them go. We continue to follow them and deal in a palliative way with the problems that they have. I think a lot of this is done on sort of an informal basis. It's only partially recorded, but a broad review of the entire institution would show a variety of cases on both sides. I think just as you say, where some people really are kind of pushed into treatment that they don't want, and then others who are followed along. It really depends upon the character, the personality, and the relationship that exists between the patient and the practitioners.
So, do you have one more?
Very quick question. So the people mentioned in the case, surgical team, patient, and daughter, who witnessed the patient's signature? Who was the witness? Because we're talking about biases.
Well, I don't know, Jackie as a nurse might likely be one of those people who witnesses the signature. And I think what's important is, and this is often a rub, I think, for nurses, is that your witnessing of the signature is only that that's the patient's signature. You're not verifying that the informed consent process was of a particular quality or what information was actually disclosed. And so, as a nurse, that also minimizes our ethical responsibility in that process, that it's not just witnessing the signature, it actually goes beyond that as a patient advocate to be able to recognize and speak up on behalf of patients when needed.
Yeah, I mean, I think we can refer to our policies here, and It says in our policy that the witness doesn't even have to be present at the time the paper was signed. They just have to confirm that it's the patient's signature. And it doesn't have to be that patient's nurse, it could be any nurse in the hallway, hey, can you witness this? And per our policy, they can pop in the room, is this your signature? And a typical practice to say, did you have any extra questions, do you understand, and all of that, but really per the policy, you're witnessing that's the patient's signature and they agree to it. But then you go to our informed consent policy, and that's where the responsibility of the registered nurse is to confirm that informed consent was done, and informed consent includes a conversation, you talk about the procedure and other options and all that.
That's actually what I meant, because they were getting, they explained informed consent, and they were getting the patient to sign. So that's what I was asking about, that the witness for that informed consent.
And I think one of the challenges in a very time-constrained environment is a lot of times when the conversation occurs, the nurse, for example, may not be present. And so you don't really know what was actually said during that conversation. So we're just about out of time. Thank you, our panel, for their words of wisdom, and thank all of you for your contribution to this conversation. It's a really important one, and one that I'm sure will be ongoing as we explore some of these issues together. Thank you.